Oh, Zubir's on. Joseph.
Right.
Morning.
Good morning. Good morning, Zubair. Good morning, Joseph. Thank you for joining. Good morning, Dr. Graham. So what we would like to do is I'd like to share with you a case and I want to thank my colleagues for helping me. This is session number 40. And I would like to thank Dr. John Stroline for his mentorship and Mr. Charles Butt for the HEB grant, Angela Deal, and my institution. So if you want to get CME, now we can get this one for free. For those who want to learn how to set up the CME, actually, I created a YouTube a video, and you could go there and you learn how to do it step by step. And once you register, you can get the CME for free every time you attend this session. So this is a case of a 70-year-old man. He was in good health. He comes from about 2 hours from Houston, and he underwent a colonoscopy in December. He was found to have a 25 millimeter polyp with a nodular area around the polyp, starting from the dentate line and extends proximal to the polyp. So the referring endoscopist did not do biopsies. I'm glad that he did not do biopsies. And then he asked us for help in terms of trying to remove this polyp. And the polyp was located on hemorrhoids. And we saw this gentleman in the clinic, and then we set him up for a resection. So I would like to ask Zubair to comment. We wanted to make this a session where the fellows would get the first shot to comment on this. And let me play this video. This is just above the dentate line. So Zubair, what do you think?
Yes, sir. Can you please play the video again?
Yeah, 1 second. And then make some co-hosts. Can you see that?
So it's difficult for me to appreciate the polyp with the from the hemorrhoids.
Right. So
I think it's just here in the beginning of the video. I just saw that with the nodularity that is extending maybe proximally.
Right. I think I should have actually given you a little bit of a longer segment. I'm sorry about that. So let me play back and then see what other people think also. So I'm going to come back a little bit. So there is a polyp there, right? And the concern that the endoscopist outside felt was this rough area surrounding this. You see this rough area here compared to the lining here? And that's
Yes,
what the
exactly.
concern was, right? The new mucosa looks a little bit different. And let me ask Roy and Sriram to comment on that. I think it's a good idea for us.
Sriram, go ahead.
Well, we see the same as what Zubair is saying. I think what we need is a retroversion view to see what is the relation with the dentate line and the hemorrhoids to look at the distal margin. And a polyp looks about 2.53 centimeters in diameter from the first look of it.
Right.
And probably the morphology is tubulovillus morphology. That particular area, probably we need to look at with NBI or spraying some indigo carbon or methylene blue to see more detail.
Yeah. All right, Roy, what do you think?
I cannot see.
I wish I'd
because-
actually cut a little longer segment because this was a long video. So I want you to comment on this area. That is,
It's very hard to see because of a few things. Number one, the cap in this area needs to be in a long position rather than a short position. When you have the cap in a short position, you want it to see the magnification view more than anything. But here you need to have the mucosa to be pushed to the side. Because you are also operating from the anus that's always closed, you need to have the cap longer so that you can push the anus and keep it open. Number two is that the CO2 insufflation is not adequate. Therefore, then, we cannot see enough where the borders is and whether there is like a rectal, is it a rectal varices there? That looks like a snake on the other side.
right, right.
I don't know what that is. So that's that. And then there is no NBI, there is no image enhanced. So at this point, there is also the last part is that there is no retroflexion yet. I don't know what this mucosa looks like. It looks like what people call as chicken skin, which signify mucosa around neoplastic tissue. So I needed more information before doing anything.
Okay. So I actually need to make a couple of points. I had a little bit of a struggle to define this lesion well because the colon, the rectum did not distend well. He's an older guy, 70 years. The second one is, I must say this, I did not, I wish I'd put a longer cap. I think you make a very good point. And the second one is, once I saw this, I said, okay, I see something abnormal. I did not go through the steps of NBI and narrowband, NBI and enhanced endoscopy using the magnification. I did not do that. One thing is, once I saw this, I've actually decided that okay, I need to figure out that there is a cell component and there is this chicken skin appearance, right? That chicken skin appearance that you saw is what I saw. And I felt that, okay, when we cut, it's not just the cell component, but also the chicken skin appearance should also come out. Otherwise, if there is some abnormality in that mucosa, then I've not done him any favors.
It is possible that this part of that flat, the originally the polyp must have been flat like the proximal part, and because of its close proximity to the anus, there must be some amount of mucosal prolapse that is causing this kind of additional traction on the mucosal surface and the irregularity. I think the key is retroversion and injection to see whether it lifts.
Right. Yeah, you're right. So I think, Sriram, you make a very important, good point here. Whether the mucosa is just a little bit edematous. It doesn't look like an adenoma type of mucosal pit pattern. And I debated, hey, should I just cut this cell component, which is small, and then finish the job, or should I be cutting all this abnormal looking mucosa, whether it is neoplastic or not? And that was my debate. And I did not do the retroflexion, to be honest with you. Basically, I saw this mucosa and then went to the next step. The next step is, because the mucosa was not, was very subtle, I felt that if I needed to cut, the best way is to mark the margin with APC. And that's what I've done here. And as I do the APC, you will see the mucosa to the right, which is a little bit abnormal, and to the left, that is normal. You can appreciate that, right? You know. You can see here that the mucosa on the right side of the APC has a different appearance to the mucosa on the left side. So that we did it on the right side, and then we on the left side, and now we're coming to the right side. You can see the lesion is very close to the dentate line. And I'm actually placing the marking at the dentate line. All right, so you can see that that's the whole area that's this thing.
Raju,
Yeah, go ahead.
can I ask a question about scope selection? I mean, did you use the upper endoscope for this, or which scope did you use?
I used an adult colonoscope. Whenever I'm doing a lesion like this, which is a little bit subtle, because I knew that when I looked at the pictures from the outside, reported that there is a very subtle mucosa, and I wanted to use the near focus. For that reason, I used the adult colonoscope. You could also use an adult EGD scope, which also has a near focus function.
Right.
But I feel more comfortable with an adult colonoscope, even for rectal lesions. You know, that's just a preference. Yeah. So one of the things that I wanted to share here is we had a PAP conference last week, I think, and Joseph and we were talking about, resecting low rectal lesions, and that's one of the reasons I brought this case. So when you have a low rectal lesion like this, when it comes to, go ahead. When it comes to injection, you want to use the needle parallel to the lining, but not like at an acute angle that we use for submucosal dynamic injection. The reason you want to get parallel is to avoid getting into the vein, because there are lots of veins here. And the second one is I used a 2% lidocaine first and injected about 5 cc's at the base, so that if my cut involves a little bit of the dentate line, the patient does not have a lot of pain from that procedure. So that's what I wanted to mention. Once I injected 5 cc's of lidocaine, and then I used the saline with methylene blue to lift the lesion. So this is what we have done. So Roy, any comments?
Looks good.
So the next question comes is, how do you resect a lesion like this? That is in terms of the snare. And I basically picked a smaller snare because I don't want to pick a large 15 millimeter snare. I picked a 10 millimeter snare, stiff snare. And then I started cutting from the edge, as you can see, but I did not use EndoCut Q cut. I used a force coagulation, 25 watts, effect 2, because of my concern about cutting over those hemorrhoidal veins. So hoping that with the force coagulation, there's going to be some coagulation effect and less likely to bleed. The other one is before I started the cut, I decided to check the location of the lesion, and this lesion was not in a dependent position. And that is something important to keep in mind because when you cut, and especially cutting over hemorrhoids, and if the hemorrhoids were to bleed, and you would not find your source of bleeding if the lesion was in a dependent position. So any comments here, Roy, Sriram, Joseph, Selvi? So we cut about maybe about a third of it, and then you could see the bleeding here a little bit at the bottom. And one of the things that I want to share with Zubair and any other fellow there is previously, previously when my settings were EndoCut Q on the left side and force coagulation on the right side. That's how I used to set up for all my cuts. But off late, when I was doing EMRs, I started changing the setting on the left side to the EndoCut Q and on the right side, soft coagulation, so that I don't have to change my parameters in the middle. That's what I've been doing. But in this case, I had to change from force coagulation for the cut and soft coagulation for the coagulation of the blood vessels. So it's very interesting. You will see here, this is almost a long video. Just bear with me. And when I was cutting on the left side, it was pretty easy. But when I was cutting on the right side, it was pretty easy. It went smooth without much problems. But the left side cut became technically challenging. And you will see my struggles as I was going through this. And why don't I stop here for 1 second? I want to go back. Okay, Roy, you see that the injection effect? What do you think is that mucosa?
Maybe it is like what Sriram has said. Is it some kind of prolapse? Is it it's hard to tell because you didn't let us use our reading glasses by having a zoom, a magnification zoom, and NBI. So I'm having a hard time looking at it. It has the O sign, so that is like hyperplastic changes there.
I'm
so yeah.
Right. So my thought process when I started assessing the lesion and cutting, I thought that the sessile component was certainly an adenoma, and the flat component surrounding this area was probably a hyperplastic. But at the same time, I was not sure, are we sure it is hyperplastic? Are we sure it is not a serrated adenoma or whatever? Because the difference between the two is so subtle that you cannot make it out on endoscopy. And
well, they could be together. They could be like serrated with these plastic changes.
Right.
So then it's one lesion.
Right.
In here, I think this looks like serrated to me.
Right. And if you remember a long time back when we were talking about serrated adenomas, almost about 7-8 years back, normally serrated adenomas, we don't see much in the rectum, but I've seen one patient where we had a serrated adenoma with low-grade dysplasia, low in the rectum. And when I saw this epithelium that looked a little bit different, so I said, okay, I better cut this one because you don't want to just cut the sessile polyp and then have difficulty cutting the rest of the area. So Zubair and others, I think you will notice that as you are cutting the polyp, you need to have some patience when you're cutting because whenever you think you are closing the snare and you think that, okay, I'll get a nice chunk of tissue, it's also possible that the snare can keep on slipping and can make it very frustrating, right? You can see that, okay, I thought that, okay, my cut should be a large cut, but it's only a small segment, and whatever segment comes, you take. And then the other thing is you keep noticing that my snare is kept relatively parallel to the wall every time you make a cut. And that keeping parallel to the wall is very important, whether you're cutting low in the rectum where there are lots of veins, or when you're cutting over a fold, because when you're cutting over a fold, if your snare is not parallel to the wall that is going up and the top of the wall and then the wall that is coming down, there is a high risk for perforation. So something to keep in mind. So here I noticed that I actually try to close and then I'm missing, right? And in that case, there's one technique that people have used, that you open the snare and then try to do a little bit of suction to let the polyp come into the snare and then close. That is something to consider. So you can see I kept on slipping and not getting what I wanted. I purposefully included this long segment of video to show that although it looks easy and it should come, sometimes the tissue doesn't come. So here, that's what I did. I suction and then try to close and then use the coagulation current to cut it. As I'm doing the case, I'm also worried that I don't entrap a big vein because entrapping a big vein would automatically lead a bigger bleed. So as you can see here, I did not know whether I got a vein underneath or not. So in this case, what I've done is I've basically distended the colon or the rectum here, and then loosen the snare to see if there's any tissue underneath that would fall back. And then again, you can see that I can loosen the snare and then cut, hoping that this will cut down my risk of having a major bleed. So fortunately, we have not had a big bleed so far, despite the area that we are cutting is lying over a bunch of blood vessels. And I'm trying to finish my last cut towards the top. You can see that even though I'm keeping my snare flat, I'm struggling with my cut because the tissue keeps on slipping. As you can see, I'm anchoring my snare and then closing, and then not getting enough tissue. So in that case, you end up putting a little more fluid, again lifting. And in this one, I did not add any epinephrine, just plain saline. And as you can see, the assistant is nicely tap, 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 so that it was a nice rhythmic lift. That way, at least, you know, if in case your needle is too deep, you're not going outside. And that's more of an issue if you are doing it in the colon, but not necessarily in the rectum. But you also have to keep in mind this lesion was located anteriorly. That means it is very close to the prostate. So whenever you're doing any resection, you have to think, hey, where is the lesion, so that you take necessary precautions, how far your needle goes in.
Generally, if it is a sessile serrated lesions, they are softer lesions. They are not firm, snare slipping kind of lesions. So the fact that there is some difficulty in capturing this mucosa on this side, that leathery appearance, etc., that does give me some suspicion that if it is more of that additional component, not the sessile component is the main polyp, but this additional component is that a prolapsed mucosa with some amount of submucosal fibrosis, because this polyp was not intervened previously to expect any adhesions related to a prior attempt. That's what I'm going through my mind. And yeah, it is a difficult location, and we can discuss later.
Right. I think, Sriram, you make a very good point. And I was actually debating myself, what to do. And when I saw the lesion, I said to myself, if I cut, I better cut completely so that I don't have a pathology that surprises me later on and then have to go back and deal with a lesion that has been scarred down from my.
I agree. There is no debate about it. Even if it is a prolapsing mucosa causing this, the polypectomy attempts will cause fibrosis, and at least that will be a different way of managing that mucosal prolapse as well.
Right. So now you actually see the resection. So the question now comes is, what are you going to do from here onwards?
APC.
Okay.
Do we need to though? Because you included a liberal margin of when you marked it, you included a liberal margin of the normal tissue, and you cut it mostly outside the margin of those markings. So which means that the margins are expected to be free.
The issue here, there are two. One is that you have this exposed hemorrhoidal plexus, and they could be injured even though they're not bleeding yet. And if you use an APC, they basically just evaporate. Is a very easy procedure to basically devascularize the area from this hemorrhoidal plexi. And number two is that the resection is very much a small piecemeal resection, and there are possibilities of having bridges that are not cut into the submucosal level. So I would just rapidly APC it and be done.
So you are talking about not just the APC of the margins, but also the surface.
Correct.
What are your settings going to be?
The APC 30 watts are 1 or 1.5 liters. Okay. And maybe finally you can then expand this rectum and take a look. All of these vessels could be just so easily be done quickly.
All right. So I think it's a good idea. So like anything else, we try to follow a protocol. So basically, I've done what I normally do all the time, almost like religion. So we decided to do the APC of the edges. I do hear Sriram's point that we got a little bit outside the margin. So is there a need? But I just decided to follow what I normally do. Sriram has a point. So we decided to do the APC. We completed the APC, And the question came was, let me ask everybody in the panel, starting with Sriram. Roy has already talked about it. What do you guys do right now? You see the lesion. Would you ablate those vessels or leave them open?
Ablate it, that hurt, and it saved the patient from bleeding.
Okay, you said that. Let me ask you, Sriram. Selvi?
I'm a little scared about the anorectal region, maybe because I'm not comfortable dealing with the anus and the pain and the telephone calls later. So I try to generally stay away from the dentate line. So that is the reason for my comment earlier about the difficulty. But also I see this case as a learning point from another perspective. From all the people that I have known, if I have to pick one person who sticks to protocol, that is Dr. Raju, where no matter what, he always goes through the steps 1, 2, 3, 4, 5, 6, 7. And to see that Dr. Raju did not do a retroversion, did not do the NBI, and before starting this lesion, tells me that it's not a comment. It's a reality of the situation. That no matter who it is important for us to tell ourselves, did I do those 1, 2, 3, 4, 5, 6, 7? And there are, with being an expert that he is able to get away with all this without any issues. But for lesser mortals like us, I think we still have to do a retroversion to define the lesion and then proceed with what was done. Probably that would increase my comfort levels in terms of defining the dentate line and hemorrhoids versus what the lesion is. And if it is close to hemorrhoids, I just try to stay away from it. I did not see a clear-cut hemorrhoid before the procedure is done. So that is not what I'm saying. But once the cuts are done, I see the Roy's point of exposed hemorrhoid vessels that we see after his first or second cut. We are able to see the underlying exposed and venous engorgement, the hemorrhoidal engorgement. That's my take.
Okay, that's good. I fully agree with you, Sriram. The only thing is when I was looking at this video, I said, I missed these 2 steps. I should have actually included them.
No, that is where what makes us human, right? Like it can happen to anybody and everybody. And the reason why I am appreciating you showing this video and also making a point to talk about it is for everyone, one of us to let ourselves know, and also if some trainees are there, for them also to make sure that yes, if Dr. Raju can do, you will do. So you better be extra careful.
All right, Joseph, would you ablate or no ablate? Selvi?
Yeah, I agree. I agree with more Sriram's comments so far. Yes, I would ablate. Yeah, both edges and probably near the hemorrhoidal plexus or at the hemorrhoidal plexus.
All right, and Selvi?
So my learning point for this case, Raju, is that we should feel a little bit more emboldened to first examine the anal rectum carefully for lesions, smaller lesions than this, which will be easier to tackle than letting something get this large, and to be able to get some courage to actually try to remove some of these lesions. So that's my learning points. The point you always make at Path Conference, which is, why didn't you just remove it? Why did you send it to somebody else to address? I don't see myself in this position having to deal with these blood vessels because I'm probably a little bit too chicken to address this type of a lesion. But I think the right thing to do would be to address the blood vessels so that they don't bleed afterwards. That's what I would do if the EMR location was different. So we should probably do that here. Thank you.
All right. I must admit here, I'm no bolder than any one of you. Once you start the procedure, you have an obligation to finish. So only thing is you play as safe as possible and taking your time. I think that's the most important thing. So I actually, to be honest with you, I debated myself, okay, should I ablate this or not? So I used the experience from a video that was published in Video GIE from a group in Kyoto, where they've actually resected a similar lesion, but they have used ESD to resect that lesion. And during that procedure, they've used hemostatic forceps to coagulate the blood vessels. And I felt that, okay, maybe I would apply that same technique and use hemostatic forceps to coagulate. You may comment and say, hey, you use two instruments. Why not? You could have done it with APC. I think that is a fair comment. Maybe down the road, when I see a case, I would probably use APC and do that. So I'm going to show you what I've done here. So we used a hemostatic forceps. We used a soft coagulation effect 80 watts. That's the setting that I used. And you probably could see what happens to the vessels when you use a hemostatic forceps. I thought that, okay, I'll take big vessels and try to coagulate. And you should also keep in mind that the hemostatic forceps come in different sizes. And if you have bigger vessels, you should at least get a bigger hemostatic forceps. I believe they are in different sizes. The biggest one is probably 6 millimeters or so. And I'm just repeating.
So if you want to use a bigger size, then you have to use a gas, because the upper GI coagrasper is bigger than the jaws are bigger than the colon coagrasper. So if you want to use the other one, then you may have to. I'm not sure about that, but this is something to be confirmed. But you may have to use the gastroscope because of the length of the force. Right. If I'm not wrong.
Right. So the other thing is you will see something that has happened here. I'm stopping here. This is a very important point for the sake of the fellows or for anybody. It's not just for the fellows. You'll see, I did a nice coagulation for the first two vessels. It went very smoothly. I was happy. And then I tried to get this vessel close to the edge and about to coagulate. And you see what happened. What happened was, accidentally I pressed the yellow pedal. Yellow pedal is a cut current, right? And instead of coagulation, it basically cut that vessel. And I could not coagulate, although I tried to coagulate. And then I felt that the best thing is apply tamponade with a clip. And this is something that I've tried before, where you could actually get the vessel nice and actually go deep with your clip. And as you can see here, we're able to basically apply some tamponade. So when I tamponade like that, I did not want to deploy the clip. I wanted to sit there for 5 minutes. I sat there for 5 minutes and reopened and looked like we were able to achieve the nice thrombosis there. And I thought, okay, maybe I should seal the vessel. And this time I applied the coagulation current. but actually the coagulation current really did not control the bleeding. Basically, it started to rebleed. And I didn't want to keep on coagulating because that area is anteriorly located, that is close to the prostate. So I didn't want to keep on coagulating for fear of causing some issues with the prostate. And then I decided that, okay, maybe I should consider clip closing the defect. So as you can see, there's a continuous bleed. And then we decided to clip close the defect from top. I picked, when it comes to closing the defects with clips low in the rectum, I tried to pick the clip with the longest wingspan here. This is a Microtech clip with 16 millimeter wingspan and a short overall clip length so that it doesn't protrude into the dentate line. As you can see, after each clip, I'm deflating and seeing how far down it comes down to figure out how many clips could I apply and how much of the defect could I close. So and I'm also trying to go and get a deep approximation to make sure that I get as many of the blood vessels as possible. And so now I stop there, right? As you can see here, I come down and I just leave that lower portion without closure because I don't want to impinging on any of the hemorrhoids. So any comments, Roy, Sriram,
You
Selvi?
did exactly what you did exactly what it's like you're at 180 degrees from me today.
Why?
Because the reason is that an APC of the hemorrhoidal plexus is so almost like I would say beautiful.
Okay.
Because it actually evaporates them. It's an amazing phenomena when you use it.
Okay.
Like the vessel just evaporates in front of you, and the area becomes nicely coagulated, and you don't seem to need a lot of power as well. And then you get all possible remaining neoplastic tissue off. You get all of the blood vessel off. I wanted to comment on what Selvi was worried about. If you had done the injection and then you had done what Raju had shown before, whereby he closed the snare and then he look up slightly, open the snare out, you will cut above the hemorrhoidal plexus because the plexus is very much running over the muscularis propria, and you're resecting at the plane slightly above that. And the risk of bleeding is actually quite small. I think some of the reason why Raju had a harder time to capture the mucosa is that, I don't know, did he have a new technician helping him? Because the snare was open too much. When you open the snare, you shouldn't see any of the straight wires coming out from the plastic. And I was surprised that you allowed the technician to have like 2 millimeter of the flat straight wires out from the plastic. Because when you do that, then the snare the snare loses its strength and can deflect upward very easily. So that is one of the potential reasons. Other than that, I think it was a complete cut, and we want to know what the pathology is.
All right, Sriram.
It's beautifully done, sir. I agree with whatever.
There, the snare is too far.
That's
The snare
exactly.
is
So
too far. Oh.
exactly, that part is actually causing a fulcrum effect there, lifting the rest of the snare a little higher. That's what I was talking about. Because of the that stem of the snare, it should not be extending out of the plastic catheter. That's the just for a quality improvement sake for our own.
Right. Zubair, you noticed that?
Yes, sir, I saw that.
All right. And I'm just doing it just for your sake, man. All right. So I just wanted to summarize. I think it took about 62 minutes. We gave 2% lidocaine, 5 ml saline plus methylene blue without epi, and snares, forced coagulation, 2 and 25, hard biopsy avulsion, APCs, soft coagulation, short clips. So it's very important, actually, once you do a resection like this, very, very low in the rectum, before you see them for the procedure in the clinic, you have to mention to them about the risk of having bleeding. They will see blood in the stool for a few days, and you need to educate them about that. And you also need to tell them that they will feel like a lump, because the area will swell up for the first 3 to 4 days, like any inflammation that happens after injury. And they will have the urge to go to the restroom, and then they can't see anything coming out, and then they strain. So you have to explain to them that they will feel like a lump in the lower rectum, and they should avoid straining. When I do cases like this that are very low down in the rectum, I always would want to find out about their prostate problems, and also explain to them about issues about urinary retention and what to do rather than stay at home. So this gentleman, what I've done is I've called him 24 hours later, and then 48 hours later, and then 72 hours later. Every day I made a phone call to him, and he had some minor bleeding, as expected. I reassured him nothing to worry about, because that's very important to reassure people, because he was about 2 to 3 hours away from the hospital, and I didn't want him to panic. I also called his referring doctor to just keep him updated, so that he knows what to expect. So we put them on a liquid diet for 2 days, low residue diet for 2 days, and regular diet on day 5. So the pathology was tubular adenoma with multifocal high-grade dysplasia, and then some the inked margins were free from adenoma, and then multiple fragments of non-neoplastic colonic mucosa with hyperplastic changes, and scattered mucosal lymphoid aggregates. So that's the pathology. All right, any comments?
Dr. Raj, how do you ink these areas to get that report, inked margins free of adenoma in a piecemeal polypectomy?
I don't do that. I think that's what the pathologists do. I think they probably, when they look at the cut margin, they probably look at one margin that is positive for adenoma, and the other margin is free from adenoma. That's probably, they really take a lot of pains to report these piecemeal resections. I don't put them in separate fragments, separate containers. The only time I put them in a separate container is when I resect a large sessile component, and then surrounded by a flat area. So the large sessile component, I put them on a separate slide, a separate bottle to make sure that they put their attention to that large sessile component for advanced neoplastic changes. The other time I put them in a separate container is when I do the resection and then there is a tethered area. Although I think that tethered area is from scarring from prior intervention, I put that in a and when I remove that with hard biopsy avulsion, I put it in a separate container for the pathologist to focus their attention to that small segment. Because if you put all of them in one bottle, they quickly scan through versus giving a separate bottle will make them focus on that particular segment.
I think it's probably worth exploring how they can do that, because and for other people as well, because then we can take that feedback to our pathologist. Because when we send them, even if you send it in separate bottles, I mean, unless you send them so those margins in separate bottles, you capture them separately and you send them separately. When they get everything in one bottle, there is no way they can look at it, and because they have to ink the histo, the gross, not the microscopically, and grossly they can't tell what is adenoma and what is not the adenoma, and all the resected things would have margin, resection margin, even if it's the center of the lesion or the side of the lesion. So they can't ink unless they know which one's from the side.
It is possible that in particular lesion, when you injected it, there is a sessile component and all the flat component. If I remember right, your second resection, the first resection was on the right margin, the non-neoplastic tissue. The second cut was included the entire part of the sessile component of the polyp. Maybe that is the only polyp, and rest of all the resections that you did were all non-neoplastic hypoplastic changes that they described in the pathology. So when you took that second bite, which was the entire polyp, probably the margins are free on that one itself, and the rest of it is all that makes it easier for the pathologist to comment. Otherwise, with this many pieces of polyp, it is very difficult to convince any pathologist to give you a report of margins are free.
Yeah, I was thinking the same thing, because I was thinking, well, if they are able to comment on the margins with this level of confidence, was the original part of the piecemeal EMR the sort of the M block of the the adenomatous portion, and everything else was hyperplastic? Can that be?
Sorry guys, they really didn't comment about the lateral margins. The way they ink this is that they I think they use like a egg white, and then they put some ink in it, and then they put the deeper margin, the vertical margin, and they're just commenting on the vertical margin. There's no way they can comment on the lateral margins, because it's not an ESD specimen.
What we'll do is we'll find out. I think, Selvi runs our PATH conference. We'll make it a point to find out from our pathologists how do they actually report the margin, and then we can get back to you. I think it's a good point to.
I don't know how practical it is, but what Roy commented makes sense. But I don't know how practical it is for you, Dr. Raju. But if you could invite one of your pathologists in one of the sessions, and maybe talk about the steps from the time they receive the specimen to the time they report it, in terms of what are the concerns of the pathologist from a pathologist perspective, and how they report on a single piece polypectomy and a piecemeal polypectomy. That would be very educational. I don't know how practical it is.
Okay, that sounds good.
The other question I have is, when you see such a big lesion close to the hemorrhoids, a 3 centimeter lesion, is it a debate always, doing it endoscopic piecemeal polypectomy unless ESD is available, versus sending it to a colorectal surgeon for transanal mucosal excision, so that they can remove the whole thing as one piece? And especially if it is so close to the hemorrhoids, they are sort of well equipped as well in dealing with hemorrhoidal bleeding if it happens during the resection. Any thoughts on that?
Roy?
when you're a colorectal surgeon and you're trying to cut this lesion, it is actually a difficult job. I don't know what the size of the patient is, but if the patient was overweight, the area is very hard to open. And then you're trying to see this lesion using a naked eyes. That is very different than an endoscopist using 40x equipment to see the lesion, and the attending and the physician can be standing up rather than putting his head into the area and trying to cut it. Who says that they can cut it in one piece? They may not even be able to see it, let alone to cut it well. So I wouldn't say that what we do is necessarily less just because we use an endoscope and we are not a surgeon. We actually have the best equipment to be dealing with this.
I think one
So
other
the answer, no, I will not refer this patient to the surgeon. I would cut it myself. Even if you have to cut using an ESD, wouldn't have made any difference if you inject plantily and cut above the hemorrhoidal plexus. The plexus is very clear cut. It's like they're at the bottom running over the muscular propria. Maybe I will try to find some movies from my prior cases to show you where the plexus is and how to avoid them during a resection.
One thing is, Aman, to keep in mind when you do ESD, you are trying to go into the deeper portion of the submucosa, just above the muscle. And you will end up having a lot more vessels to deal with in terms of the coagulation. There is a beautiful video of a low rectal ESD with one of the ESD forceps types of knives devices. I think it's a clutch cutter. I think you can put clutch cutter ESD in video GIE and see that video. I think you'll learn something. The second one is I wanted to bring this video to just let people know that if you inject well and you keep your snare parallel, you change your settings to more of a forced coagulation, and you could do the job. One thing is you have to keep in mind that this area is sensitive and use lidocaine to help the patient. And the other thing I have to not mention here that I want to mention is at the end of the procedure, I took a large, like a lidocaine gel tube, I think that comes in a syringe, I think 5 cc or 10 cc syringe. And I put some more gel into the bottom after the procedure. In the recovery, the patient had no pain. And the next 2 days when I called him and asked him about any pain, he did not have any pain. So something to keep in mind. Any other last comments, Roy, Selvi, Sriram?
Well, we're looking forward to Roy's video on the anorectal lesions. That would be really educational.
Okay.
All right.
Thank you.
I want to thank everybody and also want to wish everybody a happy Easter, and thanks again.
Thanks, great session.
Okay, thank you. Bye-bye.
Bye-bye.